why I wanted to deliver this topic at iCAAD was because I'm in recovery for 22 years from addictions, and in that time I've had to do a lot of work on myself, even though I stopped using drugs and alcohol 22 years ago. I could see the underlying issues were far deeper, really, and I could see that they kept reoccurring, even though I was clean. I could see that there was sort of core drivers that would take me back, that could take me back to using drugs and alcohol again. But however, what they done is which is really important to see, is other addictive processes started to arise as coping modes, really, for some of these behaviours. So I thought it's a really useful, and just to sort of give clarity, right? So basically, I got clean in 1996. I was in prison, so I'd been involved in way back a lot of crime. I've wrote 2 books actually. I wrote a biography and I wrote a self-help book some years ago. And the biography is all about, I was involved in a lot of drug smuggling, and so which is all relevant. This is all relevant because I grew up in a family where criminality was quite normalised. So from a young age, the sort of messages, some of the core messages that I got as a child, were that maybe we need some more, just a few more chairs. Yeah, thank you. So that's what I'm going to do in the presentation today. I'm going to sort of go through the PowerPoint, but then I'm going to open it up so that we've got a chance. It'd be really useful to get everybody to, or as many people as they'd like to, sort of interact. I'm going to make reference to a couple of books. The main books that I work from really is it's called Reinventing Your Life, by Jeffrey Young. Jeffrey Young, as you know, or you might not know, was the pioneer of Schema Therapy. It came from cognitive psychology. I'll explain further as we go on. And so, Reinventing Your Life. And the other book that I make reference to is this one here, Negative Thinking Patterns, which is also, I think, a really, really useful book. But of course, there's probably many more. And so why I'm making reference to about the sort of core beliefs. So for example, even today, years and years later in recovery, my various the core schemas that I can identify that I keep when I first got clean and sober, because it was before Schema Therapy was invented. But what I can see now was, for myself personally, I had an abandonment schema because the family, I grew up in an alcoholic family, so my father was an alcoholic, my grandfather was an alcoholic, so there was emotional deprivation, there was abandonment, there was mistrust and abuse. I'll go through some of the schemas in a little bit too, but the core ones that I could see that were getting reenacted and that still can get triggered, very much so at times, and subjugation, because I was a sort of people pleaser. I mean, there is a schema just for that, but so subjugation, deprioritizing myself, a sense of entitlement was massive. I had some unrelenting standards as well. So and there's a healthy side to unrelenting standards where there's a healthy sort of perfectionism, but it can go to the opposite end where I'm so stressed and trying to meet sort of demands on myself that are so rigorous and such like. So I could see that there was these traits. Now, what they're called in 12-step programs, a lot of times we talk about defects of character. They make reference to, you've got to work. They say often in 12 steps, if we don't deal with the defects will deal with us, or you'll get yourself into a corner that you can't get out of, clean and sober. So I could see back then that, and currently, like even today, there's a part of me there's a part of me when I wake up in the morning and I look at my wife, or when she goes, there's a part of me that can go, oh, it's only a matter of time, she's going to be gone. You know, like there's this sort of sense of that I'm going to be abandoned again, you know. And of course, how that can manifest in my life. Say, for example, there's a party and I don't get invited to the party. There's different ways that I can cope with that. So there can be a disproportionate response, you know, as regards being normal, right? What's a normal response if you weren't invited to a party? You might think, oh, maybe I was forgotten, you know, maybe I was forgotten about, maybe it's a smaller party, that it was a more intimate party. But what I tend to go into is, I personalise it. They don't want me there, they don't like me, and then I can go into different strategies around, you know, either I can sort of go to the extreme of starting to get really, really angry, and it's an overactive response to it, or I can like go into this poor me, I feel abandoned, I feel rejected, you know, and sort of surrender to it somehow. Or else I can go into an avoidance strategy where I can just like avoid the feeling completely and go into some other behaviour that takes me away from that feeling. So this is what I recognise schema therapy, and especially around people. Now, right, so I'll go and I'll start to explain so the origins, which I've just talked about by Jeffrey Young, the term cognitive psychology, you know, they're central to the sense of self. Schemas provide us with a sense of security. So that's also really important to, and this PowerPoint, you know, that you'll be able to get this. This is iCAAD. I've got this. So anybody that wants this PowerPoint, you can have this after. So the schemas maintain that because they're so hard, you know, like core beliefs we have in CBT, it's because they're reinforced time and time. For example, there's a part of me really thrives on sort of danger, adrenaline. I feel when there's no, you know, I do paragliding, I ride fast motorbikes. In recovery, I've been kidnapped. You know, so without drugs or alcohol in Peru, I got kidnapped. I got taken away into the countryside with a big knife held, like, you know, everything was stripped away from me. Now the reason why does all that happen? Why is there this part of me that gets attracted to the danger? Or I was in Peru, it was a really dodgy part of town. But I grew up I grew up in a family where there was all the time, I was often adrenalised, there was alcoholism, there was violence. So I repeat, there's a part of me that when I'm getting chased, or when I find that there's a threat of death, you know, at that point, then I feel really alive. It's a bizarre sort of situation where, you know, just as I'm just about something serious is going to happen to me, so I'm aware of these patterns that happen to me, and it's about how do I change them? How do, you know, as a healthy adult who's responsible, who has children, who has a wife, who has responsibilities, how do I identify and get sort of healthy adrenaline highs? I guess the paragliding is a really good example. I go up maybe a couple of that's sort of reasonably healthy, still quite dangerous, but I am. Whereas maybe sort of going into sort of dangerous neighbourhoods and sort of Latin American countries is probably maybe not a very good response. So how schemas relate to addiction? When treating addiction, we treat the outward symptoms, i.e. the drugs, the alcohol, whatever the addiction is. Another word used for schemas is life traps. Schema therapy is an outgrowth of cognitive, which I said by Beck in the 1960s. And what's important about, I think, for me, what's really important and why I really love schema therapy, it really deals with the unmet needs, because basically the two key drivers are obviously the person's temperament and also their life experience of what the environment that they grew up in. So, for example, with my temperament, if I'm quite sensitive, you know, if there's a sort of predisposing fact that as a child, I grew up and I'm very, very, very sensitive, And this is what's difficult to work out, isn't it? Was the sensitivity, that oversensitivity there before? You know, were you born oversensitive, or you know, this is the biggest thing about, say, 12-step fellowships, is way saying we were born with illness. You know, actually, I don't know if we're born. You know, there might be some sort of genetic predisposing factors, but I certainly think that my experience of working with lots of people with addictions for years now is most of my clients have had trauma. They've had some type of emotional neglect. They've had some sort of disturbance, psychological core disturbance when they're young, and then that creates the schema. So why I love schema therapy, and it's funny, isn't it? Because it's not. I keep thinking it's quite a new therapy, but it's actually. I was speaking to a lady before. It's like it's been going since 2004, 2005. So it's quite a while it's been going, but it's always been used in the past to deal with borderline personality or personality disorders, narcissistic personality, but really BPD. But in reality, what's became really clear now as we've went on with BPD, that's now getting recognised as complex trauma. You know, so I think it's a really, so bearing in mind that my client group around addiction, with people with addictions, they often have that deeper psychological emotional disturbance. In order not, if we don't do anything about the deeper emotional disturbance, then we're just putting a plaster. We continue to put a plaster, and you see it all the time in drug and alcohol services. They just give people methadone, or they just give them, you know, they don't actually deal with what's at the root of it, and that's and hence why the success rates for recovery, for long-term recovery, are so low, because all that happens is the person comes into a rehab or they come into some sort of facility, they deal with. Did you want to say something?
It's like weight gain on eating disorders, on anorexia. Oh, we gain weight to discharge them.
Yeah.
But you haven't dealt with.
Yeah. Yeah, that's it. That's exactly it. So we just don't, and what happens, we have a revolving door all the time, because the person leaves, you know, they go back into the world, they've been in a facility for, say, 2 months or 3 months, they've just started to touch. Now, and this is also, to talk about schema therapy, this is sort of longer term work. We're talking at least really 6 months, really work, you know. I mean, obviously you can get sort of short-term goal, you can do some sort of quick remedial work and get sort of good benefits short term, but really we're talking about longer work with the clients. So what my experience of managing and working in rehabs has been that is, you know, the client comes in, they start to do some work on, you know, their childhoods, maybe some psychodrama, maybe some gestalt. This has came from a number. Schema therapy was derived from a number of different disciplines, a bit of gestalt, a bit of psychodynamic really is put in there. We're talking about emotional needs, the deeper emotional needs. So you know, and obviously cognitive behavioural therapy as well was a massive influence on this, which, because, you know, Professor Young was a student to Beck in the 60s. So generally, you know, the person's discharged from the rehab or comes out the rehab. They've maybe cross-addicted. As soon as they're in the rehab, they're already, you know, to deal with, because they're stripped away from the coping mechanism to deal with that psychological disturbance, as the drugs and alcohol or gambling or sex or whatever it might be. As soon as that's stripped away, they'll start to and this is my experience, is they'll start to use food in an addictive way, or they'll start to want to get into codependent relationships with other girls or other men in the rehab. So they'll just transfer the addiction. Now, if that's what happens when they're in that rehab facility and they've not actually done any deeper work, because they've just, it's like changing deck chairs on this Titanic. The Titanic's going down, they're going down, but they're changing cabins on the Titanic. They've not really done any deeper work. So they walk out of that facility, and then they're dealing with life, and then something happens, and they get into a relationship, say, and, you know, this is the biggest factor really, is that a lot of people, as soon as the drugs and alcohol are stripped away, they come out, they get into a relationship, they then they're rejected, or something happens, the girl or the man finds someone else that they're more attracted to, the person's schemas then get triggered, emotional deprivation, abandonment, and then they go into a place of absolute pain. They don't know how to deal with it because they've not got any coping strategies. They've got no emotional muscle, you know, and especially if you get somebody like me, like I started to use drugs when I was 14, 15 years old, so it was like almost pre-puberty when I started to use drugs. So there's no emotional intelligence. There was very little emotional. So when I stopped using drugs, I was 32 years old. So it was like going into a party when I was 14 or 15, and then 17 years later or 16 years, I come out that party. But I've not went through all the phases that normal people, they get into relationships, they deal with death, they deal with a number of different issues. And what happens when they navigate those experiences without drugs and alcohol, it creates resilience, it creates a stronger resilience, and therefore they're able to but with people with addictions, they don't have any of that resilience really. They might have had certain times when they've been clean and sober, and they have dealt with stuff and they have grown a little bit, but generally they don't. And especially the sort of more hardcore, and I mean by that is, I mean not sort of binge drinkers or binge drug users, but more like daily use drinkers and alcoholics. So it's important to recognise. So what this does is it allows us to go back to the deeper emotional needs that weren't met from childhood, which go way, way back, you know, like, so you start to sort of touch on that, and you can use a number of different techniques, some sort of imagery re-scripting stuff, some chair, sort of gestalt chair work. I mean, it's quite innovative. You can sort of adapt it really and start to use whatever you think, you know, with what the evidence base is for that particular model, but you can implement it. So, it's not sufficient. Yes, this is why with cognitive therapy, you know, it's just dealing with the cognitive side of things. You're not dealing with the emotional unmet needs. You're not dealing, you know. And I wanted to. I'll send some flashcards around. There's another process that we use. We use flashcards in schema therapy as well to help the individual identify their key modes. Addressing these codes have a beneficial effect. The client can often use language that indicates he or she is stuck in a schema trap. I've always been this way. I've always had this problem. Schemas being hard to change are supported by cognitive, behavioural and emotional elements that determines how we feel, think, act and relate. And this is really, it comes really from childhood. The schemas are created. I mean, some schemas, especially like say the abandonment schema, you know, can be pre-verbal, can happen like when they're really young, you know, and so they estimate between 6 and 12, you know, anything up to 6 to 12 years old. But often I think they're set up really young, the schemas. So I wanted to talk, the core patterns of behaviour that we tend to repeatedly use throughout our life, and we call this the three things. The schema domain related to the emotional needs of the child. If these needs are not met in childhood, unhealthy schemas develop, which then result in unhealthy behaviour. Coping styles are the way we adapt to schemas in early life experience. They're often unhealthy and tend to maintain or worsen the problem. And schema modes, and I'll talk about some of this too, about the different modes. And there's different schools of thought about, you know, there's some lists of these are the modes, but then there's other ones that are a bit more extensive. So here are some of the child modes that are identified that happen. So this is basically, you know, what gets triggered really when a schema's triggered. This is where you can go into these particular parts of self really. If you think it as like sub-personalities really that get triggered, and this one here, the vulnerable child, is the idea of all schema therapy really is to try and identify what the sort of deep loss or the deep need of the vulnerable child is to try and repair the child. Angry child feels intensely. Impulsive, undisciplined child acts on non-core desires or impulses in a selfish, controlled manner. Difficult delaying short-term gratification. Often feels intensely angry and enraged when impulses. And this goes back, a lot of this also, attachment theory was I guess some of the drivers of this theory too, from Jung's perspective, was he was looking a lot at attachment theory, the sort of Bowlby stuff many years ago, in 2000s and before that. In the 80s, actually, when he started to look at a different type of theory. And also it's worthwhile recognising, I think, that when Geoffrey Young started to create this theory, he was really opposed by a lot of the, Aaron Beck and stuff were really quite cross with him that he created this new thing. There's a competitiveness that happens within the various circles, and so there was a lot of obstruction. He felt a lot of sort of obstruction when he was trying to sort of implement this new style. These are some of the maladaptive coping modes. Compliance acts in the passive, subservient, submissive way. So detached protector cuts off needs and feelings, detaches emotionally from people and rejects them, feels withdrawn, distracted, depersonalized, empty or bored, or overcompensator, feels and acts and inordinately grandiose, aggressive, dominant, competitive. So you can start to see how, when somebody's triggered by a particular, for example, if I use that example, say I'm not invited, or a friend, just on a smaller scale, say a friend, I send a text to a friend and he doesn't get back to me, and I send another text and then he still doesn't get back to me. I could go into either one of these three. I could go into that sort of detached, or I can go into compliance surrender, just go, oh, well, that's me, I'm just I'm just like worthless, nobody likes me, nobody likes me, I don't really, I don't deserve to have the attention of this person or this woman or whatever it might be. It can be in obviously some situations will trigger that schema much more prevalent, or I can go into that detached part too, or I can overcompensate, So then I can start to text the person back and say, why are you not, why are you not talking to me? And then I create this scenario where I almost reinforce the schema because then I'm aggressively sort of targeting the person back in some way. So this is how it generally plays out with people that I've got. Now, I'll talk about how I assess and stuff like that shortly for using this book and such like, and how I identify the actual schemas. Okay. The maladaptive, right, so where we're trying to get to is here. We're trying to get to the healthy adult. That's the whole idea, really, of schema therapy, is that we're trying to reparent. I mean, the whole is that we try and reparent that sort of vulnerable or angry child, really, and be able to identify. And we use the flashcards are really useful to start to identify where there's, how it sort of manifests in your daily thinking and your feelings. So we're trying to get to the healthy adult who nurtures and looks after that part of self, which starts to, it sounds schizophrenic really, but it is like you can identify, your core belief, your core schema, and it's how it's getting triggered, and then, how do you then intervene? How do you recognise and identify what's going on? Using the flashcards, you can see it clearly when you write it down. And then how do you start to reparent yourself? Because if you don't do that, you're going to be all the time enslaved to whatever schema is. And as I said, and especially with clients with addictions, that's only going one place really. If they're stuck in whatever schema is, whether it's defectiveness, if I'm walking around, say, with a really active defectiveness schema, I'm going to be all the time, even when I'm doing this presentation, I'm going to be like, oh God, that was a crap presentation, you know, like, oh God, everybody thinks this, and you know, well actually I'd probably never do a presentation because the defectiveness schema, if it was so active, I wouldn't even bother trying to come up in the front of the podium. So it's like, you can see that that if they're not addressed, you just stay stuck in a particular sort of routine, a set of feelings, a thought process, and therefore the behaviour that would stem from that. The behaviour, or say it's like emotional deprivation. If I'm really in emotional deprivation or abandonment, for example, I might never get into a relationship. You know, like I might come off the drugs and alcohol and food or whatever the addiction is, and might think, God, that's such a risk to get into because there's the possibility that I'm going to be rejected. So I might become somebody who just doesn't engage in any type of emotional relationship, in any sort of intimate emotional relationships. I might be somebody who then just acts out with prostitutes or has sex with different women or sex with men for that matter. But you don't develop any, and I know this. I know this from my friends that I've had when I was you know, earlier in recovery, who didn't let themselves get into deeper emotional relationships because the schema was at work here where it was going, you're going to get hurt. The projection, the fantasy was that you're going to get hurt, it's just a matter of time, you're going to be rejected. And therefore, they stopped themselves from embracing something that could be so nurturing, that can also change this schema. And the whole idea is that we're trying to change these schemas. The benefits, therapy must address all these elements. Change in only one or two realms will be less effective. Clients suffering from addiction often don't arrive at their own solution, contrary to the approach of some therapies, non-directive or adherent. Yeah, they don't. This is directive. This is sort of schema therapy is quite hands-on because it's not confrontational, but it certainly is. You're getting the client really. When I work with the clients that I work with around schema therapy, you're getting them really involved in the process. They're taking ownership. They're going, okay, well, I'm doing the flashcards. I'm looking at, you know, what's getting triggered in me. Let's look at the emotional unmet needs. You know, so they're involved in the process, which I think is really important for them, because then they feel, because I think often, especially with addiction, right, I really think that, I mean, I've had loads of therapy when I was, you know, earlier on in recovery, but also a therapy way before I got clean and sober as well, and certain types of models really didn't work for me, because what was happening in the therapy was my schemas were getting triggered by, so say it was a psychodynamic therapy where I'd be lying on the couch and it was the use of silence and quite non-directive. What would happen to me, my schemas would start to get triggered, you know, with defectiveness, or I'm not saying something, or subjugation like that would start getting triggered. So, right, so what I've done for the purpose of this now, there is 18 schemas in total, but for the purpose of this presentation, and because I'm using the book Reinventing Your Life, which have nailed really the 11 core schemas, but of course there is 18 of them. Now I'll tell the other ones at the end of this. So these are the main schemas that are identified. Let's see, and these are the extra ones here. So this is 11, and this is the other ones that are part of the full 18. We use a sequence of questions to diagnose each schema, total of 10 questions per schema. This is a marking scale from 1 to 6, right? So what I do with this book, which is important, so at the start of the book, Reinventing Your Life, he basically does a summary really to identify. So in the first 5 chapters of this book, there's a scale which starts to help me as a practitioner and as the patient or client identify what the core schemas are. Now, how you identify it is that scale, if it's 6, well, actually they say 4, 5 or 6, But 6 is, this describes me perfectly. So there's a set of questions that you read out to the client, and they're examples of when, like for example, the question, so there's a chart here, and you basically, you ask the clients questions like, that this would be unrelenting standards, people see me as doing too much for others and not enough for subjugation, sorry. I try to do my best, I can't settle for good enough, I like to be number one at what I do, or I have so much to accomplish that there is almost no time to relax and really enjoy myself. So the client then, has to answer back. I know they're quite generic, but it goes on in more detail, very thorough in the rest of the book. But this is just at the beginning stage, just as to identify what schemas might be there. And so if the client says 6 or 5 or 4, then you would go, okay, so you identify it in 2 areas, from when you were a child and also as an adult. And then from when you get the list of the various schemas, then what you do with it, you then you go into more depth at the back of the book, and you start to explore further what the marking is for each schema now, and it gives you a scale of right up to 60, so there's 10 questions. The maximum you could mark, if you marked 6 for each one of them, which this describes me perfectly. I've never had anybody doing 60, but I've had them up doing like 54, 52, really high on those particular schemas. And so once that's identified, then there's a whole set of processes that you start to do around, what are the danger signals in relationship? How does it manifest? How does the life trap manifest? And it's very, very powerful, because then the client then starts to see, oh, right, okay, this is what's at the root of a lot of my emotional disturbance. Is at the core of it is these schemas get manifest, and this is how it controls my thought processes and my emotions. We identify the impact the schema has on work, personal and intimate relationship. Identify the danger signals in relationships, because, and why this is really important is, there's different schools of thought about this, but basically it's, when you get, you come out of an addictive process, there's a vacuum, there's a massive vacuum that you often feel when there's no drugs or alcohol, whatever the addictive behaviour is. You've got, obviously you're preoccupied with that behaviour, you're obsessed with it, you're compulsive, so once you stop, then there's a vacuum really, and you've got also the sort of core schemas that are getting triggered daily really, and so there, when you meet another person, and if a woman or a man, and if they've got similar schemas, then what happens is, and it's interesting, like that saying, there's that saying, your knife fits my wound. If you've got like very similar sort of schemas it starts to manifest in the relationship. So for example, when I first, so the mother of my children, she was not somebody with addiction per se, she didn't have any addictive process really, but when I met her, she came from, so she was abandoned as a child. Well, her dad left when she was really 8 years old. So she had like a schema, really. I've never done the questionnaire with her because it wouldn't go down well, I'm sure. But I could certainly see that she was abandoned and she was emotionally deprived, and I think she had a lot of criticism even before the father left. So she would have had defectiveness as one of her schemas as well. She was a lawyer, right? She was a criminal lawyer, so a defence lawyer. So all the time she'd spent her career very, very bright. So all her life really she'd spent defending cases, right? It's probably no surprise that she picked that as a profession. So she was very robust and strong. So a really strong, quite formidable ego identity, really quite a strong sense of like, I'm right. This was another thing in the relationship, is she was always right, so there was no leeway, because she was always right, I was always wrong, of course, right? So there was no flexibility. But what would happen in the relationship is, so I've got abandonment. My dad abandoned me many times over and over again with his alcoholism. I then abandoned, so in drug and alcohol use, then I abandoned myself. So, you know, the bigger abandonment probably is I abandoned myself. I walked out, it's dereliction really, I walked out on me and went on the sort of mad spree of drug and alcohol use and whatever else. So what would happen in the relationship is, you've not emptied the dishwasher, right? You've not emptied the dishwasher. This is just a sort of like small version of it, but I'm just using this sort of small stuff really, because so what would happen is, you've not emptied the dishwasher, Mark, and you said you were going to do it, and I would go, yeah, I'm going to do it in a minute or whatever, and then she'd go, well, you should do it now, you know. And what would be happening is, she would be creating this way that eventually that I would abandon her, that I would react in a way that I would get really cross. I would feel, so it would trigger maybe my defectiveness schema. I'd feel some sort of shame, or maybe unrelenting standards, or what, you know, and then my reaction would be disproportionate. Now, I didn't know all this years ago. I mean, this is when I was first sort of like reasonably, no, it was in the first 10 years of recovery, so I was just sort of navigating, because this is what's really important, is it takes so long, recovery from addiction, it takes so long to start to get healthy. I mean, you know, it's, you know, for people to think that, oh yeah, you just put down, I mean, the government for years when I was managing drug services were like, oh yeah, you know, like long-term, the success rates are this, you know, and they only need like X amount of sessions, and then they're sort of cured almost. Once they stop taking the drugs, and the alcohol, then they're sort of fixed almost. But that's such, of course, because the drugs or the alcohol or the behaviour is a response to a deeper emotional unmet needs. All of it comes from that. I mean, Jung said at the very beginning, he said, when Alcoholics Anonymous first came, and way back, he says it's a spiritual malady. He said, they talked to Dr. Siltwood and they talked to Dr. Jung, and Jung said, you know, alcoholism, he had a client called Roland Hazard that he couldn't treat, well, that Jung sent to America to be part of this Oxford group. And the reason, and he said to the client, and then he says, look, this is a deeper spiritual, it's a spiritual emotional need. You're looking for God, really, I mean, without sounding existential, and I'm not at all, you know, but that you're looking for God in the bottle or in the drug or so, and actually it's a spiritual emotional malady that you have, and you have to, so I mean, really what we're talking about is this stuff, really, is we're talking, I mean, years later, decades and decades later, we're talking about the same stuff, is that the person, you know, so in this relationship, say, I am just aware of time, but in the relationship, this would get reenacted. She would feel like, ultimately, that I'm abandoning her, like her dad abandoned her, and then it would create rage. The rage. So it was completely from a seemingly innocuous type situation of a dishwasher, it turns into this real rage, you know, and because at the core of it, I'm triggering, I mean, this is what happened, we reenact that family script. You know, it's TA stop, a transactional, I mean, this is all mixed in, isn't it, all of it, really, but so what would happen is unless we both were able to do some flashcards at that time and say, right, okay, Vicky, we're going to have a flashcard, like, let's have 10 minutes of a time out, right, you agree on a time out, you know, and then she goes, yeah, okay, if that could happen in that moment of intense emotion, which is pretty damn hard because, you know, there's too much invested emotionally. So if you could do that, then I could go, yeah, well, what's getting triggered here is my vulnerable child. This is you're your demanding parent, you know, bum, 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 X, Y, and Z, and we're sorted, you know. But in reality, that didn't happen at that time because she was like, I'm fine, I'm okay, you're not okay, and and that's the way it sort of continued. And eventually, we couldn't like continue the relationship and on that sort of, in that respect. So, private career, reinforcing the benefit, ensuring ongoing. This is important. I've put this at the end. It's increasingly recognised that family members, such as parents, play an integral role in the treatment of substance use. This has resulted in family-focused interventions becoming common components of substance abuse treatment programmes. In addition, recent research has begun to examine the underlying risk factors for substance abuse, such as early maladaptive schemas among substance abusers and their family. And this is, and why I make reference to this, the transgenerational influences are massive within this. Where do the schemas come? Like if we look back, the schemas are developed, the child develops it based on, as I said, the temperament and the environment the child's in. It could be school as well, it could be peers, it could be, but generally it's the parents really. So if the parents, say for example in my circumstance, my father killed, he was involved in a car crash and he killed his best friend. He had deep regret, defective, but before that, he came from a family where he was criticised. So this is not, it's really important, no one's to blame, because it's not about, the family, they screwed us up, like the mum and dad screwed me up. But it's passed on from one generation to the next, really. And so my father really had a really strong defectiveness life trap. He was abandoned. Also, he was emotionally deprived. They were poor. They were from they were way back in the 30s, just after the war. Just before there was a war was set. So there was a whole number of different factors that all contributed to his own schemas. And of course, what happened as a child being around him, he continually criticised me. So therefore, the defectiveness schema got triggered. And of course, if I feel defective all the time, by the time I'm 14 or 13 and I find alcohol and I take a drink, that schema's gone. Really in that moment when I take the substance, there's no longer a defectiveness schema at work. I'm numb. It's a great coping strategy really for that. And so, but however, when I get sober and clean, I can't use the alcohol or I can't use something else because I know that other addictive processes don't work. So I've got to find a way to deal with when I feel defective or I feel when it's a really strong urge. So the family stuff, so what they're starting to do now is they're starting to do surveys and they're seeing that, that the family members of people suffering from addictions, when they're identifying their schemas and they're seeing that how they're getting reenacted. So, I've done just to give sort of clarity, I've done diplomas in family therapy. I've done a postgrad diploma in traumatology just a couple of years ago. There's, and the family therapy stuff, I when I was studying that, you could really see how it just gets past the system, it's all part of an unhealthy system. You can be the system needs to change, or certainly the person needs to change, and then hopefully the system will change. What I'll do now, as I said, at the end of this, I'm going to be here just for a short period of time, and I've got to head off because I work in Harley Street, but I've got some books there. If anybody would like to buy any of the books, you're very welcome. The two books that I'm making reference to are there, and I'm just going to open up the last 15 minutes or so for questions or any types of observations that you might like to, if anybody would like to speak. Oh, yeah.
I know you didn't go into it, but the grandiosity entitlement.
Yeah.
When I introduce that to clients, they sort of get it, but the language is really off-putting, and they can't see beyond words. I mean, if you've got better sort of definition or...
No, I know. Yeah, is that from what book is, where the definitions from, like the Jung stuff? Yeah. No, it's difficult, isn't it? It's quite restrictive, isn't it? And you're right, because sometimes I'll see with certain patients, they'll have a real issue with the terminology, won't they? And it will, So the only thing I would recommend is to adapt it or somehow use different, different language. If that was, maybe you could adapt it somehow to suit the patient, or
Or you could use it as part of the process, couldn't you?
Yeah.
What is it, do you identify with the definition, and what is it, what does that
Yeah.
word identify to you?
Yeah.
And what is it you don't like about that? I mean, that actually can be part of the process of them exploring their schema.
Yeah, absolutely,
Yeah.
absolutely. Oh, yeah, sorry, yeah, go.
What kind of flashcards do you use?
Good point. Right, guys, I'll send out a couple of these are the flashcards that I use all the time. If you send that out, then that's this one right. That's the basic flashcard. So for everybody else that's not seen it as yet until you get it, so the flashcard I use is basically quite a simple format. Just identify the current feeling, right, whatever that might be. Right now I feel suicidal, depressed, I'm sad, hopeless, and the trigger points, right? What are the trigger points? I'm looking for a job, or I'm looking at my peers from college online and they look really happy, and I'm left out, whatever it can be. And then I identify the mode, right? So what mode is it? This is probably the following mode: the vulnerable child, the angry child. I developed this mode as a child because of biographical information, wanting to be what have I put here? Yeah, getting paralysed, getting can't even read my writing. My typical coping reaction is either I avoid or overcompensate or surrender, and my coping behaviours are I Google suicide, or I Google celebs, or I don't do anything. So looking at that, and then reality testing. Then the next part under there is reality testing. Although I think that negative cognition, i.e., and then I write that out, what the negative cognition is, and then underneath that I say reality says that healthy cognition, I am a man, I am I'm competent. So I just change, and where's the proof? So then I look at the proofs, so I validate that by the proofs, and then underneath that again I've got alternative behaviours. So this has been quite useful for the clients.
How will this weave into group work?
So I mean, you could weave this into group work. Of course, you could have, you would then start to identify in the group. I mean, I generally just work with one-to-one clients with it. I've not done it in groups, but if I was in a group setting, like in the rehabs that I know, they would just get people to identify their own schemas, and they would do the sort of flashcards, I guess, and they would probably, I would imagine then having the culture of the group would be identifying like what the core schemas that are getting triggered within, like, oh, what's happening with John? I feel abandoned, I feel in the vulnerable child, or so the language would get used much more. And then of course what you would do in a group then, you start to then, a bit like you do some sort of psychodrama stuff with it maybe, and you start to identify, what does that feel like for you, John, when you're in that abandonment life trap? What is it? And and you'd start to elicit them to start bringing in their own their feelings or their thoughts about. I mean, I would imagine that's how I would implement it, I think, in a group. Were you thinking about any other?
No, it does seem applicable, and also individuals with similar schemas learn from each other.
Yeah.
So it takes some of the shame away. Like, okay,
Oh,
these are the
yeah.
things that we picked up. So I can see that could be very useful in that context.
Yeah. And the shame reduction is massive, what you're just talking about here, because once it's identified what's going on, like where it's a vulnerable child, when you don't have it when you don't have a label for it really, it's hard to it might be more difficult then to express the feelings, you know, whereas if it's you know, if it's normalised really within that group setting, that of course that would reduce the shame massively, and then it would really help the people to be like, okay, well, how do I move on from it?
They might use the psychoeducation as well.
Yeah.
They wouldn't necessarily know what it is that
Yeah, we'd need,
so
yeah. I think the psychoeducation stuff is, yeah, imperative. Obviously, before you start any group process with them, you would like inform them about, you'd get them maybe all to read the first 5 chapters, or you do a sort of lecture really about the whole thing before you start to implement it.
Are you aware of any rehabs where that is?
Yeah, I was just,
quite interesting to maybe see what.
yeah, I was at one, I went to visit one yesterday actually, and it's, they use it at a place called Highgrove, but it's part of Abacare Foundation, and they use it, and all so the people are trained in Schema Therapy, and so they use it all the time. That's their main model really, and I can see now that Schema Therapy should get used much more, you know, with addictions. Obviously it was sort of compartmentalised off to the sort of borderline personality disorder stuff, but really this is a really useful tool with people with addictions, you know. And as we know, we've all got schemas to a certain degree, but it's been able to identify the ones that disable us really, that are handicap us in that way. Oh yeah, thank you.
Do you think you can eradicate schemas, or do you think it's
No.
more realistic about
Yeah,
identifying them?
yeah. It's a really good point. I don't think we eradicate them. I still, you know, like it's been 22 years, I still have, without a shadow of a doubt, the schemas, right? I can see them really clearly at times. I mean, but more at certain things. And sometimes I've had, for example, a couple of years ago, before I got married, I just met my fiance, I just met my girlfriend, and I wound up in it was Christmas, and I wound up with her family, and there was a chap who was there, really good looking, similar age to her. So my wife's younger, right? So that weekend I had to stay in this house for the whole weekend with this guy, and I got really, I mean, it was like the worst scenario for my, because immediately the abandonment, emotionally, and we had an argument as well, which made it even worse. So we'd had this argument, and I went into, without a shadow of a doubt, I went into the vulnerable child, and then into the angry child, to the point of we're all sitting around at 12 o'clock at night, and we're playing cards, and this guy was playing cards with us, and I was like, all the time looking out for any type of glances, you know, like the jealousy was so pronounced, looking out, oh, she just smiled at him there, that's what that means, you know. And I was in a place of absolute pain. Now I was 18, so I'm 22 years now, so I was 18 years clean, went sober, so you would think, you know, you shouldn't have a problem, you should have worked through it. But in that moment, because it was such a trigger, I went to a place, and what happened at the end of the night was I said, I'm going to go to bed, because I wanted to get her, this is manipulation, the whole thing, so I wanted to get her up to the bedroom. I says, I'm not playing cards, I'm going to go up. And she says, oh, I'm going to continue, right? I was like, and the angry child was like, oh, bastard, why did, you know, like, and I was hating him, I was hating her, I was like hating the family, I was like, you know, I was thinking, I just want to be out of here. The pain of it, just sitting within the pain of that was just so intense. So I sort of walked up, and as I was walking up, it's like a big bed and breakfast that the sister owns. As I was in Whitby, I was walking up the stairs, so I'm in Whitby, I'm miles away from London, and as I'm walking up the stairs, I said she says, what's wrong? She said, what's wrong? Because she can suss it out, right? She says, what's wrong? I says, well, just just carry on playing cards with James, you know, or something, you know, that's what I said. And so, but I was raging, right? And she goes, and then she came running up, she goes, how dare you? What are you saying? What are you accusing me of? I'm here with my family, right? So she's sort of rational, right? Giving me a rational perspective. But I'm stuck in the schema, and I'm stuck in a place of, like, so then she says, well, if you don't like it, just go then. Right? So then my head is saying, oh, she wants me out here because she does want to have something with James. And a part of me then started to luckily I had the sense, just to sort of bring myself back. But in that moment, I was like, I'm just going to leave, because the pain of sitting with it felt too overwhelming, because it was really triggering stuff from way, way, way back. And then I just sat down. I says, listen, we need to sort of resolve this. It sort of calmed down. I went downstairs with her. He was still around. I was thinking of the enemy here. James, there's nothing wrong with James. But I come back downstairs, and then he goes to bed, and the relief I felt when he went to bed was like, so I didn't have to deal with the trigger. The trigger was just right there in front of me. So why I'm sharing, and if I had left, what I understand, if I had left and just reacted to it, she would have turned her phone off. Then my mind, the schema would have really played out that, oh, she's now kissing him, she's going to be sleeping with him tonight, and all of this thing that would have been on in my head. Not that she's like that as a pet, but that's what my mind. So I think what I've done is I still get triggered, but I'm much better. I've got much better at dealing with it. And the healthy adult, I've got more of a healthy adult than I've ever had, and that continues. But if I didn't do the work, if I hadn't done so much work on myself, I would just be like, I just create dramas all the time. Oh, thank you. Yeah, okay. Okay, so how do I, well first, obviously, what the chaps, what? Right, well, what I do first is I want to get them off, like, the idea is at the very beginning, I try and get them sort of balance really maintained off the drugs or the addictive behaviour, and then from there, oh, thank you, and then from there, I make sure that they've got some emotional resilience, try and just give them some strategies how to deal with their emotions and such like before, so give them some sort of emotional regulation skills. And then once that's a couple of months really to do that work. And then from there, once I feel that they're sort of robust enough, we start to do that. But then some people might be, right from the beginning, might have that resilience right away. So I have to finish now, guys. Thank you. Okay.